Hello. Oh, there we are. Okay. Everybody back to your seats. And welcome back after your break and communications. So now we're starting the next session, which is the lightning round trainee abstracts. Where myself, I'm one of the moderator, Mike Hall. We have Satish Raj and Stacy Alexander. They're going to be having discussions after the presentations. So just to give you the overview on the presentations, we have 60 minutes round of lightning presentations. Each presenter will have 5 minutes to present, and then we'll have 5-minute Q&A. So people online and attending virtually, if you have questions, please post it on the Q&A on the Whova site so that we can see your question. But each person as well in the audience, you'll get one question. We only have 5 minutes. We have 6 presenters. And you'll have the opportunity to vote on these presentations. The top 3, you can vote anytime during this session up to the end of lunch. And you can do it virtually by going to polls and then vote for the presenter. These presenters have actually been selected from the poster submissions, and you can view their posters in person during the poster session next hour, and that's over to my left, over in the side room. And you also can view it virtually on Whova. So once the presentations are complete, we'll move to a panel discussion to wrap up the session. So everybody's clear on that? Good? Okay, good.
Thank you everyone for joining me today. My discussion or presentation is on how patients with long COVID are experiencing increased blood pressure and sympathetic tone after a more than 1 year follow-up. So So first I'd like to start with that I have no disclosures. And as many, if not all of us know, long COVID is a condition that arose after the COVID-19 pandemic. Till date, there have been more than 770 million recorded cases and more than 7.1 million deaths. And long COVID itself is defined as a condition in which signs and symptoms last more than 3 months after the initial infection. And these can include lightheadedness, fatigue, shortness of breath, tachycardia, depression, difficulties with concentration, and so on. And what a lot of studies started finding was that these were similar to those experienced by patients with disorders of the autonomic or automatic nervous system. Previously, we found that a large number of long COVID patients do experience cardiovascular autonomic abnormalities. So about 3/4 of our patients met the hemodynamic or heart rate and blood pressure criteria for at least one autonomic abnormality. And I'll list a couple. One is initial orthostatic hypotension, so about 61% of our patients met the criteria for that. And POTS, which is postural orthostatic tachycardia syndrome, about 1/3 of our patients met the criteria for that disorder. When we looked at differences between sexes, we did have a primarily female cohort, but not all of the disorders had prominent sex differences. Patients with initial orthostatic hypotension were this condition was equally found amongst both males and females, and POTS was found primarily in female patients. So now that we know that patients have autonomic abnormalities, the next step was to find whether they recover. So our objective was, if this actually goes to the next slide. Oh, okay. The objective was to compare autonomic function in long COVID patients over a period of time. And we hypothesized that long COVID patients would eventually recover from those autonomic deficits over time. The way that we did this was by having patients complete an active stand test. So they laid down for 10 minutes and then they stood for 10 minutes. And throughout this, we had heart rate and blood pressure recordings throughout. We also had equations that helped us find heart rate variability, blood pressure variability, and baroreflex sensitivity. High frequency heart rate variability is a measure of parasympathetic tone. Low frequency blood pressure variability is a measure of sympathetic tone. And baroreflex sensitivity is a measure of the balance between heart rate and blood pressure. Patients also completed questionnaires that included surveys on quality of life and symptoms. And they completed this testing at an initial baseline visit, followed by a follow-up visit, which was more than a year later at the minimum. So what we found was that on average at baseline, patients were 44 years old, and at follow-up, they were 46 years old. We had 102 patients at baseline, and we had 21 patients who have completed the follow-up so far. Overall, primarily female cohorts, so 79% baseline, 67% female patients at follow-up. The time between their initial COVID-19 infection and baseline visit was already more than a year out, so 409 days. And then the time between their baseline and follow-up visits was 719 days. So, okay, so we found that overall blood pressure, both lying down and standing, was higher in the follow-up visit. We found that the blood pressure variability, low frequency measure, was higher in both the supine and upright positions, which is an indication of increased sympathetic tone. We found that quality of life and symptoms were not different between the two visits, so there was no change. So overall, we saw that long COVID patients are not recovering. It's not like the condition has gone, but they have changed over time. So blood pressure is higher, sympathetic tone is higher, and their quality of life and symptoms, however, are the same. So this will help us inform future studies on how to treat these patients and maybe understand what is the underlying cause between or leading to this increase in blood pressure. Lastly, I'd just like to thank my supervisor and team members, funding agencies, and of course, all the patients who provide time and participation. Thank you.
Thank you, Resman. We're going to open up the floors for 5 minutes of questions, both in person, the mic is there, and also virtually. So anyone with an in-person question, you're at the mic.
Included any participants who were hypertensive or were already on antihypertensive medications? And if you did you look at them separately?
So we basically included any patient that came to us, and some of them did have hypertension. No, we haven't looked at them separately, but at baseline, their blood pressure was not meeting hypertension criteria on average. So I wouldn't say they were hypertensive to begin with. Yeah, I hope that answers your question.
Thank you. Susan, any online virtual questions?
No? There we go. There's one question about, It's about the instructions for the stand test. Can you talk about whether or not there's consistency within your study and perhaps elsewhere in terms of the consistency and sort of, yeah.
There is a standardized way to do the stand test, which includes 10-minute lying down, followed by 10 minutes standing up. And the instructions are to stand up as quickly as possible and stand unaided. And then the gold standard, I suppose, for recording heart rate and blood pressure is to use a beat-to-beat blood pressure cuff, as well as have ECG for heart rate recording. That is what we did, but there is variation studies to study. Some patients or some research labs have done 5 minutes, but yeah, the standard active stand test does have the 10-minute and 10-minute. So.
Good, excellent, thank you. Any in-person questions? Okay, you have the floor.
Là, j'ai même pas le son, tabarnage.
In
Okay,
orthostatic intolerance, there's also a group that doesn't show any of the heart rate or blood pressure changes. Were they involved in the inclusion criteria of your study as well?
Yeah, we included anyone that was willing to participate in the study. We didn't
Ils ont toutes leur masque.
discriminate for that, I guess.
Hein, le présentateur, regarde.
Good, thank you. Susan, any further questions? Okay. Any more questions from the audience?
Toutes le monde dans la salle
Okay,
aussi.
good, thank you. Thank you for your presentation.
On a de la misère à les comprendre.
Sylvie is next for your presentation. Thank you, Sylvie.
Okay. Hi, my name is Sylvie Roux. I will present you our poster, Cognitive Changes in Long COVID and Neurocognitive Disorder. Yeah. Okay. Many people with long COVID have cognitive complaints, and there's an increased risk of developing a major neurocognitive disorder like Alzheimer's disease after COVID-19. Both acute and latent or chronic infections appear to increase Alzheimer's disease risk. Studying infectious agents individually does not allow us to understand the synergy that exists between them. I don't change it anymore, it changed by itself, so. Okay. The aim is to study the contribution of infection to neurodegenerative disease and long COVID. So we gather information from the literature and we developed two original concepts. First one, a simplified biological theoretical model, and second one, the concept of infectious load. As methodology, we perform, as I say, a targeted narrative review of literature on cellular mechanism affected by both infections and neurodegenerative disease. We use those two viruses for an example of infectious synergy. So the family of herpes virus are capable of latency and lifelong infections. Herpes simple virus type 1, which I will refer to HSV1, cause cold sore or genital herpes. Cytomegalovirus, which I will refer to as CMV. Oops. Causes mononucleosis. Alzheimer's disease risk is not increased by CMV alone and is inconsistently increased by HSV1, but the co-infections increase the risk and is used as an example here. In our theoretical model, we look at the synergy between acute infection like influenza and latent infections like herpes virus. So the acute infection reactivate and could be symptomatic or not. After that, they are going back to the latent state. We have many reactivation, and to some point, it can become a chronic activated infection. I'm sorry, I have a hard time to follow the. So our theoretical is divided in three parts. First one, the neurovascular unit. Second one, the neurogenesis. Are you able to replace the neurons that are gone? And last one, because we talk about infection, the immune system. In Alzheimer's disease, they are all affected, but in long COVID, the neurogenesis is preserved. There's many types of infection. First one, specific one that can directly affect the processes I talked about. And in Alzheimer's disease, maybe HSV1 is needed, as I will show you. Let's look at the neurovascular unit now. So HSV1 provokes the exact same change as Alzheimer's disease provokes. Sorry. And it causes neuron dysfunction. I am very sorry about that. It causes neuron dysfunctions. So here, that's probably where the long COVID patient stands. So we have the dysfunctional neuron. So when we do MRI, we see the neurons, but they cannot be removed by apoptosis that usually take place when the neuron is dysfunctional, because HSV1 strongly inhibits apoptosis. The next part is neurogenesis. So we have a synergy at that point. For the neurogenesis, they both CMV and HSV1, and it prevents the replacement of the neurons. In the immune system, like CMV, cause reactivation, proliferation of the HSV1 and CMV. the inflammation caused by CMV keep HSV1 active and vice versa. With aging, I'm sorry, we have a phenomenon called immunosenescence, that the immune system is decreased. And I think we have the same parameter that we see in long COVID. And we also have another phenomenon, this is called inflammaging, that we also see in long COVID. And the last part, we have the synergy between HSV1 and CMV. So each part of the system is have problem at that site. We can add ABV, like for an example, for the immune system, and we also have local and systemic infection that could add to the inflammation and to the immune dysfunction. We have all type of infection, and now we're working on AI model to put a personalized treatment, and we can, sorry about that, and we can target some specific infectious that are high for specific people to decrease the infectious load and take care of the symptoms. I'm sorry, don't. Well, so research into the contribution of infectious agent to neurodegenerative disease and non-COVID could lead to their prevention and treatment. Given that effective treatment already exists for several infections, I think it's really important. So thank you for your attention. Thank you to my lab, my PhD supervisor, Sylvie Belleville, Simon Duchesne, and all the patients that have contributed to the research. Thank you.
All right, thank you, Sylvie. That was very interesting. So
Oh,
now we
thank
open
you.
the floor to questions. Are there questions in person? And as well, online and virtual, if you can put your comments on the Q&A for questions. Go ahead, you have the floor.
Thank you.
C'est dommage, the slides were way too fast and it's not your fault. Could I have the thing? Tangential to what you were saying, but there seems to be raised CMV titers in people with long COVID. So it does seem to perhaps be a reactivation in some. And Petrino's lab at Mount Sinai did an informal study looking at 3 meds, one of which was valcyclovir. And it helped people with neurological symptoms.
Yes, I know.
And why does an IL-1 blocker, a KINRA, help some of the neuro symptoms?
Yes.
So can you, I know it's not exactly what you talked about, but it's quite close to it. Can you
Yes,
comment on
yes.
both of those?
Yes, maybe if I can go back to my slide, I don't know, to the one that have inflammation on this. So there's many, in fact, infectious agent that can decrease, or maybe it's not important to have the slide, but many infectious agent can decrease the immune system. So I think, and in fact, almost all of them, they have their immune mechanism of evasion. So if you reactivate a lot of those and you have inflammation like, and I can write, I think it's EL6 or EL1, I'm not sure anymore, but one of those ones. So you have many parts of the inflammation. So I think valaciclovir will take care of all the ones that are sensitive to this anti-herpes medication. But maybe sometimes you need other medication, like if you have a chlamydia pneumoniae, that is a very, okay, thank you, thrombogenic infectious agent. You can treat it directly, but you know, as I show in the picture, for HSV1, you can treat HSV1 or all the problems it causes. So maybe it's more efficient to treat the infectious agent at the start. Thank
Good,
you.
thank you. Any questions online? We're just going to have one question and,
No questions online that are
Okay.
pertinent to this.
okay, yeah. If you have a quick question,
okay.
that's great.
Hey, great talk. I'm a virologist by training, so I was very intrigued by your choice of viruses on the list for your AI modeling. Why are vast majority of them DNA viruses and not RNA viruses?
But in fact, it's just an example. When we do the old model, we put all the viruses or bacteria. We even toxoplasmos and other stuff. We have infection. It's just an example of synergy. So I don't want it to be too complicated. I choose only two. Thank you.
Okay, thank you. Thank you, Sylvia. Tremendous. Now, Zara, if you want to come to the podium, that would be great. Thank you. Yes. Yeah, I think the mic works online.
Can you hear me online? Okay, thank you. Hello, everyone. My name is Zara, and I'm a master's trainee at the University of Saskatchewan, supervised by Dr. Gary Groot. Today, I'm so excited to share our study on evaluating the impact of Saskatchewan Health Authority's self-management resources on improving mental health in individuals living with long COVID. Before I begin, I would like to acknowledge the traditional land here in Newfoundland and in Saskatchewan as well, where I conduct my research there. Let's get into the introduction. As we know, long COVID can significant impact on patients' quality of life. Many people living with long COVID frequently report new and worsening mental health symptoms. The treatment of this new and complex disease is challenging. Self-management can be an effective way to empower patients' skills and confidence to manage their symptoms. The Saskatchewan Health Authority, or SHA, has provided some self-management resources on its website to help patients to manage their symptoms. And the goal of my research was to evaluate the impact of these resources. Excuse me. Okay. The goal of my research was to evaluate how effective the resources are. So in terms of method, I followed a patient-oriented research and learning health system framework. I collected the data from two different approaches, first a survey and then focus group. I recruited long COVID patients who resided in Saskatchewan and had long COVID with mental health issues as a long COVID, as a consequence of long COVID. And we had a patient partner and a patient-oriented research in our focus group sessions. As you can see in survey, we can see the most common symptoms among the participants. First of all, anxiety and depression, and then fatigue and brain fog, pain, and sleep problems. And in focus group, five main themes arose from focus group. First of all, sorry, the delay for slides. Is there anything that I can do? Oh my God. Okay, yeah, thank you. First of all, we have five themes for focus group. The first of all, knowledge about long COVID. Many patients with long COVID emphasize many healthcare professionals don't know about long COVID. And the second one was many patients described they didn't know about the SHA self-management resources. And then when we asked them to give us the feedback about the available resources, they said these resources are too much content and they can navigate them with brain fog. And then, unfortunately, instead of helping people with long COVID, SHA had some negative on patients' mental health. They said something like this: it made me more frustrated. And then patient emphasized it needs support, not only information on a web page. So based on these findings, we recommended some suggestions. First of all, enhancing healthcare professionals' knowledge about long COVID, and then making patients aware of these available resources, implementing supported self-management, and establishing long COVID clinics in Saskatchewan, and revising SHA resources based on long COVID needs in both format and content, and providing a list of in-person health services on SHA website, and then bringing together family physicians and patient partner to explore helpful recommendations. So we concluded self-management can be helpful for individuals with chronic disease, but it's less effective for long COVID patients because these patients struggle more. So the findings highlight the unique needs of this group and to provide a stronger patient support. Thank you so much for listening, and I wanted to thank you.
Thank you, Sarah. That was terrific. It's thoughts in that we're all thinking about how do we get the supports in place? So I really appreciate that. Now, time for questions. So are there any questions from the floor? Okay. You have the podium.
Good talk. It confirms the reality that we as patients know. How do you propose, now that the Long COVID Web newsletter that came out the one before last quoted a document released by the Canadian government. They did a large literature survey and pegged the long COVID rate closer to 50%. Study in England, 30% or 33% of all their docs have long COVID. And gosh darn, we have a shortage of all sorts of workers. So with some kind of therapy and treatment, we could get back to work. Polio produced any degree of paralysis in about 7% of people infected. And some of the buildings built for polio rehab still exist today. So how do you propose, like, you've learned a lot doing this. How do you get the message out to healthcare workers and doctors that it's real, that we're not pretending to be sick, we're pretending to be well? Just going to a doctor's appointment is all you can do that week for some of us. So there's a real disconnect. We're talking to the choir here. We're all believers. But my GP had 2,000 patients in his practice and said I was his only long COVID patient. So how do you propose to pound it into their thick skulls that this isn't a rare condition that's just the trendy disease of the year that the patients are making up?
Hear me? Oh, sorry. I hope after these findings, we propose our recommendations to Saskatchewan health authorities and give them our recommendations to first enhance healthcare professionals about long COVID. Like, the reality is long COVID is a new and complex disease, and many healthcare professionals don't know about it. So we can consider what can motivate healthcare professionals to learn new knowledge. So we can suggest for healthcare professionals to go to CAN PCC guidelines and recommendations, or to Long COVID Web, or some Long COVID series webinars. So in this way, we can enhance healthcare professionals' knowledge, and they can believe their patients because there isn't any specific lab test for long COVID. So many patients feel their healthcare professionals don't take their disease seriously. So we hope we can make an improvement for these patients.
Good, thank you. One question from our panelist. Stacy has one question, and then we move on to the next. Okay?
Hi,
you.
is my mic working? Can you guys hear me?
No.
Satish can hear me. Can you hear me now?
Yeah.
Good? Okay. I had a question, really nice presentation.
Thank you.
My question was, when you were assessing the patients with long COVID through the questionnaires, did you have take into consideration the social determinants of health that patients often undergo when they're in specific situations of hardship, such as the differing home life of an individual, like whether it's a single mother with two jobs versus someone who has a union and is able to receive that care and support from their employer to try and help accommodate their, specific situation. I know I'd seen some of the things in the poster. I was just curious how that was assessed in the survey.
Well, in the survey, we asked some demographic information, like where do you live? For example, when patients said they live in urban area, we found they have less access to healthcare for long COVID. Or when we faced to one indigenous people, she said it's more challenging for me to read the heavy text. That's not aligned with traditional and indigenous people for learning something. So I did my best to consider some criteria, like you said. But yeah, exactly, these social determinants have impact on recovery for long COVID patients.
Okay, thank you. And I guess, yeah, did you see a correlation between the patients who may have had less social supports?
Exactly. Yeah,
And then,
of course.
okay.
Yeah,
Thank you. I
Thank you.
appreciate that.
Thank you.
Thank you, Sarah. Thank you. Okay, great. Thank you. Next is Kelly. I don't think we're related. We both have the same last name, Hall. Yeah, great. Thank you.
Okay. Hi, my name is Kelly Corinne Hall. I go by Casey Hall, and today I'm going to talk to you about one of my dissertation studies, testing a program theory for self-care strategies, optimizing mental health. So building off a little bit along the lines of Zara's theme. I want to thank the University of Saskatchewan and the Saskatchewan Centre of Patient-Oriented Research for taking me on and providing me funding. Okay, so I think that we know there's a huge connection between long COVID and mental health, but I kind of wanted to talk about this phenomenon and this gap in existing research that long COVID has several persistent and diverse symptoms, and there's a heavy self-care burden. Most people that get long COVID are told to do self-care and self-management. And the literature shows what self-care is tried, but not why it works for some and not for others. And that's what I wanted to explore. Can I just yell slide? Does that work? Thank you. Okay, so this is a realist approach, and I did realist evaluation. So if you're not familiar with that methodology, it's a theory-driven approach. So that's the theory that I was developing. And it seeks to uncover what's driving the change. So how and why programs work or why they do not work. And how you do this is through a CMO framework. And those are kind of your hypothesis statements. So C is for context. It kind of identifies the condition or the setting in which the intervention is applied. Mechanism is the process or trigger that makes the ways in which an intervention produces its effect. So we like to call it the magic. Maybe that's just me, but why is the effect happening? And the outcome is the result or change that occurs from that mechanism. So my question is, what self-care strategies work for whom in what context, and why. So we developed 10 context mechanism outcome statements. And when I say we, it's myself, an MD, an RN, a psychiatrist, and a computer science academic, as well as 3 patient partners. We've worked together for 3 years on this project, and this is the 3rd step of our project, developing this initial program theory that is now being tested in patient populations in the prairie provinces. So this is very specific to Alberta, Manitoba, and Saskatchewan, because we know that rural prairie provinces have a little bit of a different landscape for accessing healthcare services. Okay, so the process for testing the theory was recruit a bunch of people on Facebook, administer an 80-item survey so we could get some quantitative metrics of where they stand with mental health, as well as some of those social determinants that you were talking about earlier, Stacy. And then we did interviews, 2 interviews, 1 get to know you, 2 where you're actually testing these statements, seeing if they agree, disagree, what the nuance is. We move into an analysis, member check with my patient partners, and then we do theory refinement. I know I'm talking fast, I only have 5 minutes, and I'm very excited to show you. Next slide forward. The preliminary results. So here are the 10 initial theories and initial statements. On the left, the CMO statement. And so I'm going to point out just 3 of them. And on the right is the refinement that is happening based on talking to patients who are living with long COVID and what they told us. We're now refining the theories to better involve and relate to their experience so we can truly explain what is going on. So the second one is about pacing while juggling work, daily tasks, reduces stress and improves mood. We found this to be true, but there's a lot of nuance with that because, oh gosh, I have to quick, because you have to learn how to prioritize. So it's very stressful before you get the skill of prioritizing to be able to pace. We also saw that focusing on personal values, things that are meaningful to them, and self-kindness reduces anxiety and depression. But really, it supports the grieving and the emotional adjustment that patients and people living with long COVID endure, and it helps them feel more resilient. The last is expert empathy reduces anxiety and depression. And I think this is very true in the room. I've heard it over and over again with all the long COVID events, but that validation buffers stress from bureaucratic and symptom unpredictability. Because the biggest nuance that we saw missing in our CMOs is we didn't talk about how managing disability services really impacts your mental health and your ability to have quality of life. All right.
All right, thank you. That was excellent. Questions from the audience? Okay, 1 question.
Hello.
Hi.
It's a pity you didn't get more time because it was a very interesting poster presentation. So bearing in mind that I think your statement was that people suffering from long COVID find it very difficult to manage their own self-care, and a lot of the programs that are being offered involve that. And I completely take that on board. Dr. Funmi Okunola, practicing GP and CEO of Long COVID, the answers.
I remember you from last year.
We are in a healthcare crisis in terms of healthcare professionals. The general 1 in 5 Canadians have no family physician, but we have a rising number of people with long COVID. Currently 9% of the population, around 3 to 4 million people are suffering with long COVID in Canada at the moment. So how do we square that circle? Because there are, we have 400 million people, if you're looking internationally, with long COVID. We simply don't have enough healthcare professionals to manage that large cohort of need. So there's going to need to be some form of self-management of people's health. So how do we square the circle with that fact and your findings? How do we kind of provide the support that long haulers need?
Yeah, it's a great question. So I think at the end of my dissertation work, I'll be working with my patient partners and other folks about how do we make this knowledge translation? Who do we need to be talking to about this? And I also think that it might be even taking it back to the long hauler groups of, hey, we found this. What do you think we should be doing with this information? And so I'm really going to lean on my patient partners as the ones of like, hey, what is effective ways to communicate with your healthcare team that you saw change? And how can we get this out there? But also, what are some social supports and some things that the long COVID community can do for each other to help with this self-care? Because there's so much exchange of tips and tricks and support there that I'd really like to tap into a resource that's already being accessed.
Okay.
Okay, great, thank you. Yeah. Is there any online questions, Susan?
Yes, there's one, which is just whether or not people with CFS or delayed PEM were part of your study.
It was only folks that had long COVID. They may have a dual diagnosis. I did not ask.
Okay, thank you.
Yes.
I think we have room for one more question. Yeah, thank you.
Thanks. I'm really curious, like there's a lot of focus clearly on patients and people with long COVID, but we know that this is an overburdened group anyway, right? They're dealing with long COVID. So I'm curious, like, does your research point to any structural changes that could happen to facilitate, the things that folks are going through without putting a lot of more pressure on them?
Yeah, I totally understand. The focus of the CMOs were really on individual behavior and interpersonal connections. I didn't go beyond the system level, but I do think that's kind of a next step. I think Zara did more of the system level evaluation of what's going on, and I looked at more the individual and interpersonal factors.
Oh, interesting. Okay, thanks.
I'll be presenting my poster tomorrow if you have more questions.
Okay, good, thank you. Thank you, Kelly. We have two more presenters. Marion is next. Thank you, Marion.
Good morning, everyone. I'm Marianne Balem, and today I will present to you my postdoctoral research called The Impact of Long COVID on Work Functioning among Quebec Healthcare Workers. Okay. For some long COVID cases, common symptoms such as fatigue, cognitive dysfunction, or shortness of breath can affect their ability to meet their job's demand or their job's responsibilities, and that we called the work functioning limitations. To date, several studies had evaluated the impact of the long COVID on work functioning limitation. Sorry, can you just, thank you. So several studies has evaluated the impact of long COVID on work functioning limitation, and several of them had mostly focused on the identification of a risk factor of associated with not returning to work. And for the other, they mostly focused on the symptom severity and on which factor which symptoms were associated with work functioning limitations. So these questions are really interesting, but some questions remain unanswered. Some questions like which factor are associated with work functioning limitation on still at work population, and do these associations differ by long COVID symptoms? And these questions are particularly concerning for the healthcare worker because they had a higher risk to be exposed with the work functioning limitation due to the long COVID. So our study aimed to respond to this objective on this specific population. So our study consisted in the survey implemented by the INSPQ on all healthcare workers in Quebec with an online questionnaire. The participants consisted in COVID-19 positive controls and in long COVID cases. The cases were categorized in 3 subgroups according to their long COVID symptom severity, and both controls and long COVID case were healthcare workers at work at the time of the survey. About the method, we collected some individual characteristics about the sociodemographical and also about 3 symptoms-related factors, about 3 work-related factors. The next, please. And about the work functioning, which was measured by the 2 questionnaires, the work world functioning and the work ability. To respond to our objective, we estimated some regression models. The predictive were these 6 symptoms and work-related factors, and the outcomes consisted in the work world functioning score and the work ability score. Our first result was that the 6 predictors were associated with a decrease in the work functioning, and it was particularly true for these 3 symptom-related factors. This result in with healthcare workers with higher exposure of dyspnea or cognitive difficulties or psychological distress had a lower score compared to the healthcare worker without exposure. We also observed that the moderate and severe low COVID case with higher exposure to at least one of these factors consisted in the huge decrease of work functioning. And this huge decrease resulting in a reduction of almost the half of the full work functioning and the full work ability. And these scores were clearly and significantly lower than the controls. So the greater exposure of factors were associated with work functioning limitation, and this association was markedly stronger for moderate and severe long COVID cases. So our finding showed that the work functioning of healthcare workers with moderate and severe symptoms was comparable or even lower for certain cases than people with chronic disease such as cancer or multiple sclerosis. But this, unlike this well-recognized chronic disease, the long COVID has not yet a formal recognition in workplace. And so can you pick thank you. So a formal recognition of low COVID and workplace accommodation in workplace are urgently needed. And this workplace could be, the next please, could be in the reduction of work demand or to address psychological distress or other symptoms-related factors with cognitive rest period, telework option. So this accommodation could further facilitate the work functional recovery and the job retention for healthcare workers or for among all populations. Thank you for your attention.
Marianne, thank you very much. It was a really interesting presentation, especially trying to document impact on workplace. So, any questions from the audience? Okay.
Less a question than a huge thank you. It's proven reality. And we don't send postpartum mums back to work full-time 3 days later. We've learned to be more humane, and there's tons of benefits from that. If you could wave a magic wand, how would you change things? And I know nosocomial infections affect hospital workers as much as patients. Wales keeps statistics on this. 75% of the people so sick with COVID they have to be hospitalized caught it when they were at the hospital for something else. So what does that say, you know, going the step before this about N95s for everybody? Last time I was in our local emerge, they wore masks, a lot of them surgical, a lot of them under the nose, except the doc who wore it like this. You know, it's kind of like wearing your condom on your finger. So that's the step before, but you've learned a lot. If you could wave a magic wand, what 3 things would you change?
You mean before the infection or no?
In anything. Now that you know this, what would you like to see done differently? And if you were the ruler of the world and not Donald Trump, what would you do differently?
Yes, okay. Thank you for your question. I think it's just, you know, the beginning of this kind of research, because we need a lot of recognition and a lot of process. So I think maybe, you know, with this result, we can say that in the COVID-19, the long COVID clinic in Quebec, the most prevalence is the moderate and severe cases. But between the moderate and severe cases, there are a lot of changes and a lot of differences between the symptoms, the severity of symptoms. And I think, you know, with this kind of research, we can focus on the needs of the patient, and especially for their work. And I think we need to share the information with the employer and all of them, because sometimes we just need to change little thing. And I don't know, I'm not, you know, I not change everything, but some accommodation and just formal recognition in workplace for every employer. I think it will be a real change for this patient.
Thank you. Thank you. Susan?
Thank you. One question. Just your ideas about how one might accommodate for cognitive dysfunction in healthcare workers.
Yes. Sorry, I don't understand the question.
How might employers accommodate people with cognitive dysfunction in the workplace?
Oh, I don't know the percentage, but in our sample, the moderate and severe case, these people, the moderate and severe case concerning like the healthcare worker with higher exposure to cognitive dysfunction, concerning like 30 to 50% of the severe and moderate case. So it's for our sample, but I don't know, do you know the accommodation about the employer, because we don't have this data for the moment for this sample. So thank you for your question.
I think we have room for one more question. Go ahead.
Yes, thank you for your presentation, very interesting. And many of the workers were able to get back to work. The problem when they get a new infection, they have a big
yes, down again.
Yes, yes. So and it's usually not a week off. It's usually many weeks. They are going to decrease their function. So did you plan to accommodate that? Did you make a recommendation on this particular, because it's quite common that it happens?
Yeah, thank you for the question. So I'm actually working on the other study with worker with long COVID and the workplace, and we have an open question about these trends and this limitation about the workplace and the employer, and a lot of these workers with a fall down, they quit their job or they change their job, you know. And this is not my recommendation, but we saw this about them, and a lot of telework is when it's possible for sure, but the telework and the leeway job is very, very important. It's not like accommodation, but it's like when you can change your manner in the work, and the leeway job is very, very important for this kind of patients. Thank you.
Okay,
Thank you.
Vivian, thank you very much. Now, our last person was our first person, and do we have a better connection with Hamida to do a virtual presentation?
Hello, everyone.
Any luck? Yeah. Do you want me to ask her to speak? Hamida, you can go ahead and present. Thank you. can I ask her to? Okay, can you hear
Hello,
us?
everyone.
Hamida?
Yeah, I can't share my screen. Karen, could you please help me?
Okay, they're on it. They're trying to help you there. So hopefully we can sort of, any luck? Okay, they're try again now to see if you can start.
Disable at screen sharing. Yeah, sure. Thanks. It's no result. Yeah. Can you see my screen?
Do you think we could play her 5-minute recording? You can see
Yeah.
her on the screen? Okay, excellent. Okay.
Can you hear me?
We can hear you. Thank you.
Okay, let's start. Hello, everyone, and good morning. My name is Hamida Qazizadeh. I'm a postdoctoral researcher at University Health Network, and today I'll be presenting a pilot study exploring the genetic risk factors related to Long COVID using whole genome sequencing. This work was conducted under the supervision of Dr. Chang in collaboration with Dr. Amir, our genetic consultant. I have no disclosures to declare. As we know, Long COVID affects thousands of millions of people globally and seems to be influenced by different factors like age, sex, severity of disease, and vaccination status. And mechanisms likely involve immune and genetic factors, but genetic aspects of Long COVID is poorly understood. So in this study, we aimed to identify genetic risk factors that may contribute to Long COVID. We analyzed whole genome sequencing data on Novasec platform from extracted DNA from 45 non-hospitalized Long COVID patients with symptoms lasting at least 3 months. 70% were women with mean age of 41 years and 75% identified as white from the Canadian COVID-19 longitudinal cohort study. In the genotyping analysis, using a candidate gene approach, we analyzed 162 candidate genes selected from a literature review to focus on variants most likely associated with Long COVID. So variant filtering was restricted to rare variants in exonic or splicing regions, and pathogenicity was assessed using predictive tools, multiple predictive tools, and then variants were cross-validated in ClinVar and Franklin and Versum genetic databases. As a preliminary result, 45 Long COVID out of 45 Long COVID cases, 43 had pathogenic variants. Among these 43 cases, we identified 30 variants, including single nucleotide variants, changes in a single DNA base, and copy number variations, which are larger structural changes of DNA segments. In our cohort, most Long COVID cases carried at least one variant. Specifically, 11 cases out of 43 Long COVID cases had both SNVs or single nucleotide variants and copy number variations. And these genetic variants are involved in immune and inflammatory responses, platelet activation, and viral entry. We know this study has some limitations, including a small sample size and a lack of matched controls. We did analyze 40 age and sex matched recovered controls from the same cohort, but it's a small sample size to have any significant or meaningful differences. In terms of strengths, this is the first study to apply whole genome sequencing to Canadian individuals with Long COVID, providing a new insight into a genetic susceptibility to Long COVID. As we know, larger and diverse cohorts will be needed for validation of these results. Therefore, we have submitted a proposal to Long COVID Web to expand this small pilot study into a larger cohort, which is currently under review. As a conclusion, our pilot study suggests that genetic variants may influence susceptibility to long COVID. These variants may act as modifiers, influencing long COVID symptom persistence and severity. And our findings support a polygenic susceptibility for long COVID, which is then influenced by other factors like environmental and clinical factors. Understanding these genetic factors may help identify at-risk individuals and develop better treatments. And I would like to thank the CANCOV cohort study participants for their invaluable participations. And we thank the Canadian Institute of Health Research for funding the CANCOV cohort study, the Genome Canada, and the Center for Applied Genomics for their support in conducting whole genome sequencing. Thank you, and I welcome your questions and feedbacks.
Okay. Thank you, Hamida, and that came through loud and clear and perfect. So thank you.
Thank you.
I'm going to take questions from the audience. Satish, do you have a question now, or?
I do. I don't know if is the mic working? So thank you for that. It's a methods question, actually. If I understood what you were saying correctly, you were only interested in rare variants, and what you found in 10 or 11 of the 43 were isolated variants that were found in no one else. But that may have been because of what you looked for. My question is, why did you look for that? If you know, we're trying to figure out if there's a susceptibility gene, why would you look for rare things that may be unique to individuals rather than things that might be common across multiple individuals? I mean, we don't know the prevalence. There's thrown out that it was 50%. The Quebec data suggests in healthcare workers it might be 10%. Either way, neither of these qualify as rare.
Good question, thank you. And if I correctly understand your questions, as you know, we use whole genome sequencing that sequences all regions of DNA, including region and non-coding regions, and allows us to detect small indels like this type of variants like long COVID. So we, in this study, we focused on rare variants, you know, and the next step in the future, we may focus on other types of variants like common variants.
Yeah, Hamida, connection is sort of limited, so we've got a sense of it.
Other
Thank you.
classification of variants.
Okay. Susan, do you have a question from virtual?
Yeah, there's two if there's time, but the first is EDS UK states people.
Significant variants.
Hamida, we will have another question now for you.
Thank you. EDS UK states people with HEDS type 3 are 30% higher risk for long COVID. Do you have any plans to correlate your findings to increased risk groups such as HEDS or neurodivergent individuals?
If I correctly understand, we can focus on genetic screening to identify susceptible people to long COVID, specifically in other regions with long COVID.
Okay, another question, Susan?
Yes, thanks. Would it be worthwhile to get genetic testing done in long COVID patients? And if so, how do you go about doing that?
Hamida, did you hear that question?
I can hear, but it's breaking, you know, I can't hear clearly. Sorry.
Yeah, we'll repeat it again.
There's also a suggestion that perhaps you could turn off your video, so maybe there could be a clear interface there. The question is, would it be worthwhile to get genetic testing done in long COVID patients? And if so, how do you go about doing that?
Can't turn on my video, I don't know why, can't find susceptible people to long COVID. So it can help us to identify susceptible people with a viral syndrome. We can use these results for other
Hamida, what we'll have to do is we're going to hold off any more questions now. It's hard to get a good connection. So I just want to thank all the presenters. That was excellent, a very excellent variety of presentations. Everyone give a clap. So now we have 20 minutes for discussion. Is that, you're the boss? So with our panelists here, if you have some general discussions about the presentations or in relationship to long COVID, here is your opportunity. Thank you.
The panel mic's on, please. Can you hear me now? Okay. I was going to ask the question if the audio wasn't so bad. I was really interested to see if, and someone might have read the paper. I didn't have the opportunity to read the full paper. I looked at the poster and reviewed, but I was curious if we're going to see some of these genetic mutations or changes involved in some of the study that just won the Nobel Prize for Medicine on the FOXP3 gene in autoimmunity. So that was a huge finding, and I was curious to know. So maybe she may be able to answer that through the question and answer on Huva. But yeah, that was something that I was interested in.
I mean, I think what I got is that there's actually quite a spread of work, and a lot of it, certainly both Saskatchewan projects, are focused on ongoing challenges and difficulties in terms of access to care. I guess I was a little uncertain in the first presentation of what was being asked, either to disseminate better the Saskatchewan Health Authority plan or not to, because it actually made mental health worse. I wasn't sure if saying we should disseminate it more is better, right? But I think it speaks to a broad challenge, right? And it's a challenge of limited resources and access. So the question is, what realistically as a community do you want to ask for? You can say we need better resources, we need clinics, but it's been 5 years, right? If this was going to happen, if the floodgates were going to come, it would have come, right? So I think we need to be very focused and realistic. And if self-help, approaches and tools are not the solution, then is there another low-touch approach that can help with care? I think data suggests it's not going away. I think that fits with probably the experience of a lot of people here, but it's not clear how we should move forward.
Yeah, that's one thing that I've been struggling with here in Newfoundland and Labrador. We don't have a long COVID clinic. We never had, well, we have an amazing doctor, Dr. Ira Manise, who has taken on every single patient that gets referred in Newfoundland and Labrador pretty much with long COVID. And she currently is running the long COVID ECHO program. But in terms of access to care, even our Newfoundland Labrador government website doesn't have information for people with long COVID. And listening to the presentations, it echoes within the long COVID community. People sometimes need assistance with other things in their lives that are now roadblocks and hoops to jump through because they have chronic illness. And I thank you for doing this research. I'm like getting emotional here, but it's a matter of when people are in these situations, having all of this extra paperwork. So in education, we accommodate based on the needs of the child. And that's something that there's a gap between when we're looking at how we accommodate humans, right? Like we should be accommodating humans for what they need help with. And each individual is different and each situation is different, because it might be as easy as someone saying, okay, well, you can work from home the majority of the time, and for in-person things that we really need you to, you can do that. And then it gives that person the opportunity to pace a little bit better, less exposure in the workplace and things like that. So that's something that I really want to thank you guys for bringing that up in your presentations and just considering the specific situations. But do you guys have anything to add to this? But I really, really am thankful that people are looking into this and there are being studies done in this area, because it is very much needed.
Yeah, all the presentations give such a variety of research in different areas. We're looking at basic research, genetics, we're looking at etiologies that are causing long COVID, but then we're also looking at the practical aspects of it. When you are a person living with COVID, looking at how does it impact the workplace? How do we get that message to the people that you're working for to say, we have statistics data that says these are the people that you will need to give more accommodations to. So we also need that literature and that research, because we need to move forward with long COVID. We have more and more patients who have long COVID. COVID has never gone away. It's continuing to infect people with infections. There's a significant risk of getting long COVID. And if you look at the number of people who have long COVID for many years, we're adding people on top of it. So this, in my mind, this is probably the public health issue, medical issue of urgency that we should be facing now, and they should be addressing, and in the near future. So in my mind, it's important to have all of this ongoing research for all these different areas so that we can move forward. That's my thought.
Absolutely. Yeah.
My background. I wanted to highlight something I thought that was really well done in the Quebec healthcare workers study, and that is that it didn't treat long COVID as one homogeneous group. And I think that's actually a problem that I see in a lot of literature, is that people, and it's not unique to long COVID, it occurs with other disorders that I think are actually a cluster of things and not one thing. But certainly from an autonomic perspective, it's silly to say long COVID patients should have X or Y or Z, because it depends on their individual phenotypes and they fit into different groups. In that study, they had the controls. The overall COVID group looked to be about 10%, of the population, assuming that this was selected in some form of randomness. And the interesting thing is there was one group that they didn't talk about, right? They broke it down into low, medium, high severity. I think the terms are a little bit different. And I saw data for the controls in terms of the numbers of work efficiency ability, and for the moderate severe, but the lows weren't mentioned. And I took from that the lows actually do fairly well. Now that was about a third of the group, I think, or maybe a quarter. It wasn't the majority of the long COVID group. But I think that's, one, it would have been nice to see that data presented as well. But I suspect its omission was because they do well, and by weller. And I think it's important to recognize that. I think at times as a community, we want to make the number really big. But I'll tell you, if you actually go to a system and say half the people have this huge disability and deal with it, from a management point of view, I think the first instinct is to run and hide, right? I mean, that's an impossible task. As opposed to if it was 5% or 6%, whatever that number was in that Quebec study, that's still a huge number, right? But that might be something you can accommodate. At 50%, you can't accommodate it. You have to sort of just, destroy the system and start over.
We always want to have some positivity in this disease. So you look at there are patients with mild disease with chronic COVID whom get better, who functionally are able to function. And we know also the people who are disabled by it. So it's such a variable disease. And I think that's the message we have to get across. It's a complex disease. We have 220 symptoms associated. It can affect every organ in your body in different ways in different people. So I think I agree with you. It has to be individualized. We have to have ability to take this patient and say, you have this type of long COVID with this type of severity, and this is the accommodations that are required for you. If we can individualize it, because it's such a complicated, complex disease, but yet it's a chronic illness. So
Yeah, and is my mic on? I just wanted to thank everybody here who's wearing a mask here today, because I would not be here if you guys weren't wearing a mask. And a lot of us that have long COVID have immune dysfunction. Mine comes along with an immune deficiency, and I'm able to get sick more easily than others. But one of the things that was very difficult and a difficult process for me was going through this situation to get a workplace accommodation. And with long COVID and post-exertional malaise and post-exertional symptom exacerbation, having all of these extra things to do on top of your regular everyday life, it's near impossible. Yeah, and not everyone can do it. You know, it can cause a huge crash and a lot of stressors. And I think that's what we need human resources management to be educated on. How can we help our employees if it's not negatively impacting someone? If someone is accommodated in a way in which they can thrive, they're functioning better and they're going to do better. So, I mean, I think that's something that also one of the presentations showed. Just if you are able to do something, you're going to be more productive at work. So management wants people to be more productive. Let's accommodate people in the way that they need to be accommodated. So, yeah.
And it makes the point that with this disease, we need those supports. We need to somehow get the message to public health that this is an urgent disease that needs to be supported. Patients need to be educated. Health professionals need to be educated. And we need to educate health professionals so we can develop teams to support all the patients, because there's a lot of people out there. It is such a common disease. We're missing a lot of people with it. So, and it's having this research that you guys are doing in all these different facets, getting the data, getting the information so that we can present this to the people who are in charge of the funds that's going to set up long COVID clinics, that are going to say, yes, you're right. We need to educate the public that we have no treatments yet, that you need to talk about COVID, try to avoid long COVID, get your vaccines. But not only that, for the people that are affected by long COVID, we need the information to present to these people to say, this is the data, you need to do your part so we can get these people better. So
could I just, I think actually, I'm going to disagree with something you said. So you said at one point, we need to educate the public and health providers, okay, there's no treatments and stuff. And I think if you were to say that there's no treatment with good evidence, that's 100% correct. I will tell you that if you go and tell healthcare providers that there's no treatment, you've just now given them a reason not to see the patient. Because why am I spending time seeing this patient if there's nothing I can do? And I'm not sure that's the message you want to deliver, right? I mean, you can argue how effective the treatments are and they may need to be individualized, but I would argue that there are treatments with crap evidence currently, but there are treatments that help somewhat. There's no cure. And I will make one other rant, and I'm be interesting to see where the genetic stuff lays out. I will put my quarter down that 5 years from now, it'll amount to nothing. Because, you know, I've been watching the space for 25 years since the NIH Genome Project, and people expected the Genome Project, once we understood the DNA, that disease would be solved, treatments would get cheaper, life would be better for everyone. And the truth is that for rare diseases, it has made life-altering differences. Maybe for people with severe cholesterol management because of PSK inhibitors discovered from people with rare diseases, it's made a difference. Where's the disease for myocardial infarction? Where's the disease for hypertension? Or where's the gene? Sorry, there's the disease. It doesn't exist. These are polygenic, and there's a whole lot of complex things going on that's beyond the level of the gene. So there was a question about, well, how do we get this genetic test? I think it's a mistake to wait for it. I don't think that it's going to be there. And even if it's there and we say, okay, you have this gene, sucks to be you, it doesn't make someone better, right? They're still as sick as they were, and you still have to treat them. And I think there's a fool's goal in sort of expecting the genetics to immediately lead to treatment. And it has happened in rare cases and rare diseases. It almost never happens for more common things.
Yeah, good point. Yeah, good point. Yeah, absolutely. And I take your words right that somehow with the health professionals, we need to give them the message, you can help patients with long COVID. Do we have any treatments that are approved right now? No, but there are things we can do to help. So, and that's what we need, people who are educated in long COVID so that they know that there are things they can do. So I agree with you there. Yeah, thank you.
Yes, I think Mike meant no cure for long COVID, but there certainly are things that we can do to help treat symptoms, and I think it's important for physicians to be educated on that too.
From a physician point of view, the reality is that while we like to think we cure people, most of us don't, right? Someone has an itch and we find a way to scratch it. I would argue even my interventional cardiology colleagues who like to put stents in things, you're not fixing the underlying problem, you're treating the acute problem until the next one comes along, right? My colleagues that ablate Wolff, Parkinson, White, and accessory pathways, they may cure it because that pathway doesn't come back, but that's a minority. And so I think the sense of I'm not interested unless I can cure something is a fallacy. Like if you actually look at anyone's practice, like rarely is anything really cured. Maybe the oncologist, if you survive their treatments, maybe that gets cured, but it's really rare overall in medicine. Like, have you cured asthma in kids? Like you manage it, you treat it. That's what we do.
Excellent. Oh, are we taking questions from the audience? You have a question? And one second now. So we only just have a couple of minutes left. So we'll probably queue up after that. So go ahead.
Really good points. And what I've learned, and I liked what Dr. Raj had to say particularly. The only time a doctor really cures is when they get the earwax out. And I've yet to meet a doctor that didn't love doing it because of the effect. I have some ideas. I belong to a group of 20,000 patients in Canada, and we found the most effective way to recruit, and it comes right out of these studies, is to start first and foremost saying, we believe you. And to say you're going to have supportive people who will believe you, know what you're dealing with, and they can refer you to appropriate specialists and give you lab recs for the tests you need, because we can't get that normally. Mild disease you addressed. One of the things that's missing is the horrendous falls, traumatic brain injuries. And that's even in people with mild disease because we don't have feedback from our feet. We don't have good proprioception and our inner ears are screwed up. So it's sort of the trifecta for falls risks. And talking about a blood test, Manali Mukherjee at McMaster and Akiko Iwasaki can say definitively, we see these test results only in long COVID patients. But it goes back to, you might as well just believe us, because Akiko said 94% of the people who thought they might have long COVID, she can prove they have long COVID. So just believe us. We're all type A people. We need to have easy access to treatment and financial support. We were all professionals. We had good income and suddenly we have none. And that your data needs to be used to convince people like workers' compensation boards. There are nurses who got sick at work and they can't get any support. So, and the last thing is we need research as well, but we also need integrated, not just multi, but interdisciplinary care, like a good rehab hospital, for instance, one file per patient, things like that. So everything you've said, it's just like, yes, yes, we really agree. So thank you for this session.
All right, thank you. I think we're going to clue up now. I think it was a really excellent lightning round. We had certainly a great variety of presentations and a great discussion. So thank you to you guys for participating, and thank you to all the audience.